Okay, we're going to be talking about the evolution of fat transfer and how we've gone from just big globs of fat transferring to nanofat. I did cover some of this in the non-CME lecture where we talked about tulip evolving with us, but now we're going to talk a little bit more about the science and the technology in general. So these are just my disclosures. So in the 1970s, plastic surgeons were just taking big chunks of fat and moving it to different places. And we realized that the fat was not vascularized and it was dying, it was getting necrotic. And so in the 1980s, a lot of plastic surgeons started doing dermal fat grafts with the idea that if the fat disappears or goes away, at least the dermis with a little bit will create some fibrous tissue and create some fill of the tissue. Now, we did have this, and Patrick brought up a very good point, that while there were some trailblazers like Guy Magellan in Paris who were starting to use smaller cannulas and get smaller particles of fat, Dr. Coleman was still using big cannulas for the harvesting at that time, but he did validate the concept that putting little droplets of adipose into distinct tunnels in the soft tissue does lead to viability and long-term results. So while Dr. Coleman was still using the big cannulas for harvesting, others like Guy Magellan were shifting towards the smaller cannulas. And then in 2001, from the University of Pittsburgh, mesenchymal stem cells were identified in adipose tissue. And prior to that time, we were injecting adipose tissue at MD Anderson for patients that had radiated skin, and we were seeing that the skin was softening tremendously. And at that time, we didn't even know that there were stem cells in skin. So it was really kind of, we finally solved the mystery. And then around 2010, around that time, Drs. Ternard and Verpale really pioneered the concept of nanofat and brought that to us. So this is just a slide I think I've shown a couple times of a whole adipose graft. And of course, if you take this and put this somewhere else in the body, it's not going to revascularize, and most of it is going to become necrotic. And so that was the problem with the whole adipose graft. And this is just a picture of a dermal fat graft, which is kind of the way we used to do it before we had all of these new fat transfer techniques. So the clinical outcomes were better with the dermal fat grafts than the fat grafts alone, but still it wasn't very satisfying. So Dr. Coleman showed us that if you take adipose tissue and put it little droplets into distinct tunnels in the soft tissue, that you can get structure and that you can get long-term viability and long-term results with the fat transfer. And this is just a schematic, a diagram that just shows, the concept of small particles of adipose tissue becoming revascularized. So for the surgical technique, whether we're making microfat or nanofat, the harvesting, from my perspective, is pretty much the same, and the difference comes in the processing, what you do with the adipose tissue once you harvest it. And then, of course, what end product you have and how are you going to inject that into the tissue. So for the adipose harvest, we're typically below the level of the superficial fascia. There are some reports recently that were published in PRS that showed that adipose cells from the more superficial areas actually have more ability to stimulate more active stem cells in that particular layer. So, but adipose tissue is a difficult tissue to work with. There's a learning curve. Even after all these years, we still accidentally squirt fat on the ceiling or get it on the floor, and we joke that fat is a messy business, and it definitely takes some learning curve. We have to make sure the patients have enough adipose tissue because many patients come in and they just don't have sufficient donor site areas. I have patients that come in to see me in Miami pretty much every month to convince me that they've gained weight and that they're fatter, and they get them on the scale and they weigh the same exact amount, but they come back every month hoping that they'll have enough fat for a fat transfer procedure. And so the pre-op planning is very important. Now for the harvesting, I use a tumescent technique, and we do the lipoaspiration with a handheld system for these small volume fat transfers. When we're doing microfat for breast reconstruction or breast augmentation or gluteal augmentation, then we're using a power system. But for many of these procedures, we're using a handheld aspiration system. And then, of course, as Dr. Tortlin mentioned this morning, minimal manipulation is a very important concept in the United States. The FDA does not want us using collagenase. They don't want us to be manipulating the tissue and manufacturing a biodrug. So this is the recipe that we use for the tumescent fluid, and we pretty much use this same recipe all the time unless somebody has a particular allergy. And so we take a 500 ml bag of injectable saline, and we put 25 cc's of 2% plain lidocaine in there, as well as 2 amps of 1 to 1,000 epinephrine and 10 cc's of sodium bicarb. Cannula selection is very important, and as Dr. Tonar pointed out, the concept of microfat is really harvesting adipose tissue through smaller cannulas so that you have smaller particle sizes, and that's a very, very clear and helpful definition. This is just one of the instruments that I've designed, and the port size and the configuration is such that the particles come out in a very nice size. I have tried the barbed cannulas. I found them to be too traumatic for my patients, and so we've been using these types of cannulas, which are sharp on the port edges, but they don't have barbs that stick out. So this is an infiltration cannula, and it's a single-use disposable cannula. And in the syringe, we have the tumescent fluid, which has that recipe of ingredients that we just talked about. And then we're doing a bimanual technique where you're always feeling where the cannula is in space. You don't want to go down deep and go into the peritoneal cavity, excuse me, and you don't want to go up too superficial into the dermis because you can cause bleeding and contour irregularities. You see, we're doing this under local anesthesia. The patient is having a great time having her adipose aspirated, and never seen patients so excited to have a surgical procedure when you tell them you're going to be removing some of their fat. If you could play this as well. This is just a little video animation showing the process of tumescing the adipose tissue. Can you play this one as well? So after we've put the fluid in, we let the fluid sit for 20 minutes, and sometimes we found that even 25 minutes is better than 20 minutes so that the epinephrine can constrict the blood vessels. And while that fluid is sitting in there, we're preparing and getting ready for the rest of the procedure. So now that the fluid has sat in there for 20 to 25 minutes, now we're going to perform the handheld lipoaspiration. So put the cannula into the tissue into a more distal area so that you can maintain your suction, and then pull the plunger back, and then once that lock snaps, then you have a good amount of negative pressure, and that draws the adipose tissue into the ports, and then the sharp edges of the ports will shear the adipose particles and bring them into the syringe itself. So typically, the harvest should not have any blood. It should be bloodless. I work a lot, I do a lot of interspecialty collaboration, and I find that the orthopedic surgeons who try to do this are always in a hurry. They only wait 5 minutes, and then they call me every week and say, there's still blood in my lipoaspirate. I say, how long did you wait? Oh, 5 minutes, but it seemed like a year. So go check some emails, make a phone call, but don't just stand there and watch it. I also use a twisting motion as well as the back and forth motion. I find that when you twist, this is the configuration of the ports on this cannula are in a spiral configuration. So as you are going back and forth and twisting, you really maximize the exposure of the adipose tissue to the ports in the cannula itself. So once the adipose tissue is harvested, we take the syringe lock out. And again, these are procedures that the vast majority are done under local anesthesia in the office. The patients like that as well. Then we take the air out of the syringe and then put the syringe upright in a rack. It's very important to maintain verticality. Sometimes if we do these in the operating room and the nurses will take the syringe that's just settled and turn it, and then you kind of have to go back and start from square one again. But once you let it sit for a little while, then the tumescent fluid goes to the bottom, the oils float to the top, and then you have the adipose tissue in the middle. Now again, when we're doing microfat and we're doing large volume, we're not centrifuging. However, for the small volume cases, we are centrifuging in certain circumstances. So this is we use the Coleman technique for the centrifuging at 1200 G for 3 minutes. That's basically what we do if we're going to centrifuge the adipose tissue. And then once it's centrifuged, you have the oil at the top and the adipose tissue in the middle, and then the tumescent fluid at the bottom. Now, when we're injecting into soft tissue, we're using blunt cannulas to a great degree. There are some indications now and thoughts about using needles, and I think what Dr. Tonard and Dr. Verpel presented with injection into the dermis itself with a sharp needle is absolutely has a lot of validity to it, and I think the results speak for themselves. Could you play this video, please? So this is fat transfer, this is just basically microfat, okay? So this is for structure, not nanofat. We're not putting it through a screen. We do a little bit of emulsification to just make sure that the fat flows smoothly. But you can see that the patients tolerate this very well. There's just a little wheel of anesthesia at the entrance site, and I did not do any infraorbital blocks or mental nerve blocks on this patient. And she's tolerating the procedure fine. And if you could play this slide, please. You can see that in a very vascular area like the head and neck, you can cover a huge amount of ground, a huge amount of area, and not get any bleeding or have any issues with regard to with regard to hematomas or getting into blood vessels and things like that. So again, this is microfat, this is structural, and this has nothing to do with nanofat. This is to provide structure in a patient who's very, very deflated. This is just another example of microfat transfer, liposuctioning and doing body contour, and then injecting for, for gluteal augmentation. This is another example of a microfat transfer for breast augmentation. We have many patients now coming in Miami saying they want to have their implants out and they only want fat put in. And I think for a woman who's 50 or 60 to know that she's not going to need another surgery for her implants when she's 80 is kind of a comforting thought. So we're not only using it for reconstructive cases, but we're using it for cosmetic cases and really very pleased with the results. But the problem with the microfat is that when you try to use it in areas where the skin is very thin, you can get things like this. Now, thankfully, this is not one of my patients, but it's just an example. It really scares you, and it really makes you think, wow, I have to use that nano filter, and I really have to get it to be more fluid and less chunks, because this is a disaster. And once you have this, it's a very difficult situation to treat. So the evolution of nanofat came in, I think, primarily when we were working in the lower lids. That was where we were first seeing so many problems with thin skin and very, very little subdermal tissue. And then, again, we were taught about the concept of intradermal injections, which also can help a little bit with the contour regularities. So the evolution goes, you can see the big glob of fat on the left, and then the microfat, and then the nanofat. Now, there's been some discussion as far as what is, when you go through, you take the adipose tissue, you go through a 2.4 millimeter transfer, is that automatically nanofat? And we don't consider that to be nanofat. We still consider that to be microfat. As a matter of fact, when we do fat transfer procedures, that's how we load the adipose into the injection syringe, is by using a 2.4 millimeter lure-to-lure standard transfer system. Now, I do agree with what Dr. Verpel said. If you're doing vigorously back and forth many times, you will rupture some of those adipocytes by the Venturi effect coming back and forth through the syringes itself. But I do think that a little bit of passing through the lure-to-lure transfers is helpful, because it does eliminate the fibrous tissue and it's similar to what Dr. Tornado and Verpel do, where they actually directly take the fibers out as the adipose tissue is on top of the cloth. When you go back and forth, you'll occasionally meet some resistance. You'll have to open up the syringe and pull out a little fibrous strand. So we do advocate some lure-to-lure transfer, but the more transfer you do and the smaller the lumen, the more fat cells you kill and the more it becomes like nanofat. So for nanofat, we're taking the adipose tissue and then we're running it through serially smaller lure-to-lure transfers, 2.4, 1.4, or 1.2. We did try to eliminate the 1.4 transfer, but we found that there was still some benefit to going through, and maybe it was just more passes through these syringes themselves, but we've actually gone back to using all three of those transfers. And then again, what comes through is very liquidy. A lot of the fibrous tissue is trapped within that double screen mechanism, and you do have the stromal vascular fraction, the stem cells, and probably many exosomes and cytokines in the nanofat, which is helping us. If you could play this as well. So this is the FDA is saying that they do not like the word emulsification, and they would much rather hear the word resizing. So now we're not emulsifying, we're resizing so that we can be within the minimal manipulation guidelines. But you can see that you meet some resistance as you're starting to push this adipose tissue through the 2.4, and then as you get down to the smaller lure-to-lure transfers, the adipose tissue, the consistency of it becomes very milky, and then you get to the point where many of those adipocytes are ruptured. And then the nanofat production, once we've resized, not emulsified, then we pull it through the nanofilter, the transfer system, and you can see that the syringe on the left, the lighter colored one is nanofat, whereas the one on the right is just freshly harvested microfat. But we did have to take that microfat and get it from a 60 cc syringe into a smaller syringe, and we did that with a 2.4 lure-to-lure transfer, and I wouldn't consider the darker colored adipose tissue to be nanofat at that point. It's still microfat. And again, just showing this, the centrifugation, we took nanofat and we centrifuged it and we compared it to microfat and centrifuged it, and you can see that there's just a little bit of adipose tissue right here, that most of this is the oil, whereas the microfat had much more fat tissue component to it. And this just shows what the consistency looks like, and this is, I think, a great example of why you would not want to use microfat in the lower eyelids. You can just see from how the adipose tissue lays on the gauze there. The nanofat, again, is very liquidy. And this is from one of the landmark articles from Dr. Tornado and Verpel and their group, showing, as they showed this morning, the green is for staining adipocytes, and you can see that with nanofat, there's almost no fat in nanofat. So it's kind of fascinating to see, but this is why you want, when you're doing structural fat grafting, you're using microfat because you want the adipocytes to be viable and alive. But with nanofat, you really don't want the fat cells. You just want the stromal vascular fraction. So it's kind of interesting because nanofat, to a certain extent, is a misnomer because there's really not much fat in nanofat. So, and then this shows the intradermal injection with the needle, which is advocated by Drs. Ternard and Verpel. And this is their work from that publication. And I think that when we all saw this in the plastic surgery community, we were just amazed, to see things that we were not able to achieve with any other technique. And I really think we owe a great deal of thanks to these two doctors here for helping us to develop tools that we can use to treat our patients more effectively. So the pearls, the harvesting technique matters. The cannula selection absolutely matters, and that's where we go from just fat harvesting to microfat using smaller harvesting cannulas. And then the adipose processing and injection technique are also very important. Now, I started to do some nanofat injection with blunt cannulas. And I'm also an otolaryngologist before I did my plastic surgery training, and I've done lots of facial fractures and been in that area a lot. And I know that there's not much thickness to the dermis, and it's a very thin, compact unit between the skin, the dermis, the muscle, and then the periosteum. So I started to use the tulip cannulas, or the disposable cannulas, with a small gauge to see if I could get as good results with that as with an intradermal injection. If you could play this video, please. So you can see that the skin is quite thin here, and that with the blunt cannula, you really can, I think, in my opinion, get up into the subdermal region fairly well. The question is, do you need a sharp needle to really get that nanofat into the dermis? So I may come back next year and say, don't try this. So I'm not advocating this. We're trying to see with some patients if we can do this with a cannula instead of with a needle. And the patients are absolutely less bruised and traumatized, and they have less downtime with this particular technique versus using a needle. If you could play this one, please. And you can see here that, I mean, any more pushing, I would probably pop through the skin. So, I mean, am I subdermal here? I think so. But we'll see, you know, how the results are. And this is a case that I just did a couple weeks ago, so we have not gotten much, you know, we're not expecting to see a lot for at least for months to come. But you can see that with the blunt cannula, you can really get a lot of good control, and you can, and that is the video that's shaking, not my hand, not my hands. So anyway. And then you can see on the table that the right side is really nicely filled, and there's almost no bruise. So the patient came back within a couple days and was out doing things in public and not even having to wear makeup in that area. So you can see this is one side, the tear trough on the right side is done, and now we're going to go to the left side and do that. But it's nice to do the procedure and see the patient have so little bruising. And then, of course, they go home and tell their friends it wasn't so bad, and the friends look at them a couple days later and say, yeah, you're right, it doesn't look too bad, and then, you know, we go from there. So non-healing wounds, you know, I'm going to go through, you know, just some of the different applications. You know, Gino Brigatti in 2007, he showed that if you just do fat transfer to a particular area, you can get neovascularization, you can get wounds to close. And this is another example of microfat, not nanofat, a case of Dr. Coleman's for reconstruction using structural fat grafting. This is a case that I did that was, sometimes you do need microfat as well as nanofat, and the combined treatments sometimes are needed. So for this case, we needed some microfat to fill in the tear trough, but then I also wanted to use some nanofat into the skin itself to help with the dyschromias. And the patient definitely has an improvement in the quality and the texture of her skin, and we're still seeing her for follow-up years later, and she's still getting more improvement. So it's fascinating to see that the process seems to continue for quite some time. For periorbital rejuvenation, again, I'm using microfat for these cases where you really need to kind of restructure the lower lid. She didn't have that much in the way of dyschromias. This was microfat, not nanofat, structural microfat. And this lady was a smoker, and she came in, and I put 45 cc's into her perioral area. And I literally like panicked when I went home at night, and I said, oh my gosh, she's gonna look like a monkey, or she's gonna look horrible. And then she came back in, and I was like, wow, I could have put another 20 cc's in there, but I couldn't imagine, you know, 45 boxes of Juvederm on the counter. Like, so it's really great to have this tool and be able to do this much filling with autologous tissue. This is another case, combined microfat, nanofat, and facelift and blepharoplasty. And the nanofat was used in the area of the lower lids and was used with a needle technique. She's done very well. The quality and texture of her skin is definitely improved. We have many patients with hand rejuvenation that we do in Miami, and also a lot of the cases we do in Asia, where dark spots on the hands are considered not a good thing, and many women in particular in Asia walk around with gloves on just so they won't get dark spots on their hands. So when I started to do these procedures in Asia, it was amazing to see how well received and how many patients it generated. This is a case of a knee rejuvenation. This is an attorney, an immigration attorney from Miami, who came in and she said she was complaining of that when she was in court that the judge was looking at her knees and she was losing cases because she had saggy knees. So she asked if I could do anything for her knees, and so of course, because she was an attorney, I had to say that I've never done this before, but the principles of structural fat grafting using microfat apply to different areas of the body, and that we really don't have a lot to lose except maybe a little bit of fat. So you can see a liposuctioning from the thigh and then filling in many of those contour irregularities which created shadows in her knees was really helpful for her. So we really have evolved, and I think we're continuing to evolve, and I think next year we're going to have a lot of new information and updates on things, but there's no question that adipose transfer, whether you're using macrofat or nanofat, is a great tool for both cosmetic and also for reconstructive procedures. It is absolutely harvest dependent, and I think this has been said more than once today, but garbage out, garbage in. So we have to make sure that we're doing the harvest the right way, or you're not going to have a good result. Definitely indication specific. I also, in my next talk, we do a lot of interspecialty collaboration with dentists and orthopedic surgeons. So we really have to be careful, and understand what we're treating and be very specific with our indications. Injection dependent, and will that blunt cannula be helpful in the lower lids? We'll see. I hope so, but there's no question that the injection process and technique is very important as well. And now we're moving into this whole area, shifting gears from the microfat to the nanofat. We're shifting gears from structural and cosmetic surgery to more of a regenerative medicine pathway with all of the exosomes and things that are in the nanofat. So it takes a team effort, and I think we're all learning a lot from each other, and we still have a long way to go. We have no idea how this works, as Dr. Tenard said, but we're getting close to it, and I thank you all for your attention.